Hi, my name is Madison Engel, and today I'm going to talk about cystic fibrosis. So just a little bit about cystic fibrosis. It's autosomal recessive. It's caused by a mutation in the CFTR gene. So this is going to end up reducing life expectancy, and it's going to lead to some chronic illnesses, which we're going to get into later. It is more apparent in Caucasians. It appears in about 1 in 3,500 Caucasians, and it has a life expectancy of about 53.1 years, but this has improved since 2006. And then the most common variant that we're going to see, it's about 85.5% of people have this variant, and it's the F508del variant. There are some others, but this is the most common that we're going to see. So let's get in a little bit more in the patho of this. So this mutation in the CFTR gene is actually going to cause exocrine gland function issues. So there's going to be a defect in the chloride and bicarbonate transport, and this is going to cause a lot of mucus backup in the lungs, pancreas, liver, and intestines. So problems that you're going to see with this, your patients are going to have chronic bacterial respiratory infections, and that's going to be one thing that's really big with anesthesia and one thing that we want to look out for. Other things is bronchiectasis, pancreatic insufficiency, malabsorption. This can cause a lot of those issues. And then you're going to see a lot of progressive lung damage just from that mucus plugging and all of that mucus damage. So now a little bit more about anesthesia implications. So let's talk about some triggers. So hypoxia and hypercapnia can happen from the mucus plugging, and you can have some potential bronchoconstriction just from the DES. So if you're going to use desflurane, it's probably not good for these patients. We definitely want to avoid desflurane with these patients. So a good anesthesia approach is for anyone with cystic fibrosis, regional anesthesia, and total IV anesthesia. That's going to help with that mucociliary clearance that we want to see. Use humidification because we have all of that mucus built up in the lungs, and you want to use cautious sedation. So I think of an example, we use Versed a lot pre-op. Maybe use something that's not going to cause so much respiratory depression, because respiratory is going to be a big issue with these patients. We want to use bronchodilators like albuterol, and again, we want to avoid DES. So these patients are going to have some good monitoring. For sure, we want pulse ox and capnography because hypoxia and hypercapnia are some big triggers for these patients. We want enhanced cardiac monitoring. We want them on an ECG, and we really need to frequently suction these patients. They have a lot of mucus, and we need to do frequent airway assessments as well. And then some challenges is always just going to be airway and secretion management too. So as far as the clinical presentation, you're pretty much going to see what I've already described, and that's that thick, sticky mucus that's going to cause a lot of airway management issues, and it's going to be difficult for them to clear. They're also going to present with recurrent respiratory infections, and you might even see some wheezing with that. They also have comorbidities usually, so the CF-induced diabetes, osteoporosis, and liver disease. I also wanted to touch a little bit more on the volatile anesthetics versus the propofol, because it's been shown that your patient's risk of developing bronchospasm and laryngospasm is lower with propofol than volatile anesthetics, specifically DES. So treatment regimens for these patients, a lot of these patients are going to be on CPT and the high frequency devices, usually those vest devices. And some medications we'll see them on are mucolytics and CFTR modulators, and we'll also see them on pancreatic enzyme replacement because those exocrine glands are going to be affecting our pancreas too. And so these medications are listed in the PowerPoint. We'll also see them on a high calorie diet. And in advanced cases, these patients are going to be candidates for lung transplantation. So how do we get to the diagnosis? They are going to do a sweat chloride test, and if it is over 60, then they are positive. Intermediate levels, so usually like 30 to 59, they're just going to require some follow-up with some additional testing as well. And then they're also going to be doing genetic testing to test for those variants that we've already discussed. And again, the F508del is the most common. So going into some more testing, these patients are going to be getting PFTs, usually FEV1 or FEC, and they're also going to be getting a chest CT, an MRI. A lot of these things we can see before we undergo anesthesia. And also sputum cultures. They are going to be testing for pathogens very often because these patients are very susceptible to respiratory infections. So genetic testing is going to be a really big deal for these patients. It's going to assist in identifying the CFTR mutations with newborn screening. So they are going to use the IRT for this. And again, about 90% of patients are going to have that F508del variant. So the mutation is going to be in the chloride channels. It is the CFTR mutation. It is classified in 6 different groups, and globally, this same variant is going to be linked to very severe lung disease. So getting into the specific receptor, it's going to be the CFTR protein. And usually this protein is going to assist in epithelial ion transport of bicarbonate and chloride. And what happens is during this mutation, it's going to cause a lot of mucus backup and plugging. It's going to cause viscous secretions and impaired mucociliary clearance. So this variant was identified in 1989, and back then it was very supportive care, but now you see a shift starting at about 2012. They have seen an increase in very targeted therapies instead of just supportive care. So some recent case studies that I found, this first one talks about spinal anesthesia with 0.5% bupivacaine, or about 10 milligrams, and this was helpful for patients with the G542X mutation, and using vitamin K for coagulopathies was helpful as well. And then the next article, they talked about Reddit posts. So they went through Reddit posts and identified patients with CF and really connected all of their concerns, their problems, their symptoms, and their treatment regimens. And they found a new tool to be more effective than the existing tool in helping providers, anesthesia providers specifically, for us, better help understand the issues and concerns of patients with CF. And this could be very important to us because we will come across these patients, and patients with these disease processes are probably very anxious about undergoing anesthesia. And so the better we can understand them, the better care we can take care of our patients. So now for susceptibility and genomic screening. It has a carrier rate of 1 in 25 of Caucasians, and it detects 90% of cases for early modulator eligibility. For anesthesia, pre-anesthetic genetic profiling to guide anesthesia, you want to avoid desflurane, which we have already discussed. It's going to decrease our risk of laryngospasm and bronchospasms and manage coagulopathy risk. So now for anesthesia practice, for anesthesiologists and CRNAs, this is going to be a very big topic. We need to know how to manage these patients, especially with the high respiratory involvement. So we want to optimize preoperative care and assessments, understand their baseline, understand their respiratory and how many respiratory infections they've had, if they have one right now. Really look at their testing, the physiology, lung recruitment. They need to have PFTs, and they need to have adequate suctioning while they're in the OR, and an adequate airway assessment is going to be important as well. And your care plan, and we've discussed a few options. Really, we want to stay away from volatile anesthetics, especially DES. Propofol, total IV anesthesia is going to be very beneficial. Also, we have discussed from that case study that 0.5% bupivacaine spinal anesthesia is going to be a good option as well with managing their coagulopathies. And multidisciplinary collaboration is going to be important. We want to work with our pulmonologists and our other professions that are going to have a lot of knowledge about this disease. So in conclusion, anesthesia is going to be very impactful with these patients. We need to have very tailored approaches for these patients that we already discussed, with the desflurane and the propofol and the spinal anesthesia. If we want to take a multidisciplinary approach to this, we need to have careful considerations of their mucus buildup and their recurrent bacterial respiratory infections. And we want to keep in mind that research is ongoing and that we need to stay up to date on the newest research too. And here are my references. Thank you very much for watching.